I get the privilege to introduce Dr. Klein White. I also want to share before I introduce Dr. White that we're extremely thankful for Dr. White and Mrs. Amy White, who have been generous hosts to help the National MPS Society this year manage this beautiful family conference as they live in the Denver area. And a lot of what you see in some of the vision is because of their work that they put into this. So thank you very much. If we can have a round of applause, I'd appreciate that. Now to Dr. White. Klein White is the chair of the Department of Pediatric Orthopedics and the Rose Brown Endowed Chair of Pediatric Orthopedic Surgery at Children's Hospital in Colorado. Dr. White is an internationally recognized expert and advocate in the care of MPS and skeletal dysplasia. He serves on the Medical Advisory Board of Little People of America, the Scientific Advisory Board of the National MPS Society, and is the principal investigator for multiple international research studies on emerging treatments in rare diseases. I'm so happy to know that we have someone like Dr. White caring for our children, and let's bring him up on the stage.
No walk-up music? Thanks. No walk-up music, huh? Hard to follow the fundraising group. My gosh. No, thanks, Terri. I was just talking to Dr. Baker, who's going to be giving a pulmonary talk later, and he said, yeah, how long have you been doing this? I said, well, 25 years now. So anyway, yeah, it's really great to always be part of the MPS Society conference, and it's especially special this week because we get to be in our hometown. And so please feel free to approach any, we have our whole team here, our metabolic team. Raise your hand, Janet and Leanne, and who's over there? I can't see in far. All right, anyway, so please feel free to come approach any of us. And we do have a little booth out front, and our team will be there as well. So with that, we'll talk about orthopedics. And the funny thing about Amy is last night after I went to bed, she went and fixed all the bullet points in my PowerPoint because she didn't like them. So if you see attention to detail on anything, it's her. I do have some disclosures with some of my research projects that I do, but nothing that really is affected here. And I think I have been involved for 25 years because this little one, Susanna is my daughter. She was diagnosed with MPS 1 in 1999. And she had a bone marrow transplant. Dr. Bronlund took care of her, a lot of the Minnesota team. Unfortunately, she passed away in 2008, but very much has been an inspiration for me in this journey. So we'll just talk about bones and joints. So you probably will hear the term dysostosis multiplex, and really this is just Greek for multiple bad bones. And it's really a term that's for some reason applied to MPS and ML disorders. It's a diffuse skeletal disease. It's very much related to GAG accumulation and the inflammatory response that we get as a result of that GAG accumulation. It results in children in deformities. So we get knock knees, spine deformities, hip dysplasia, and so forth, which I'll talk about. And I'll also talk about in adults, it results in degenerative joint disease. So hip disease, knee disease, and necessitating joint replacements and so forth, which Dr. Bronlund's already alluded to. So here's I'm going to show you a couple animations today. This is bone development. This is normal bone development. Our growth plate sits at the end of the long bones, and it makes these very nice columnar structures that then lay down bone. And this is how our bones grow. Now, in MPS, it's a little bit different because of this inflammatory change and this response. You get this accumulation of glycosaminoglycans. And you lose that normal columnar development, and then that's what causes abnormal bone growth in MPS. When we're talking about interventions, and this really should apply to any surgery, but of course I'm talking about orthopedic surgeries. We need to ask, is it going to improve your function? Is it going to remove pain? Or is it, and most importantly, is it going to improve your quality of life? And here's a little checklist of things that you can look at, sleep, happiness, mental health, and so forth. Because if you're walking around miserably in pain, then your quality of life is not going to be good. Sometimes you might just have an X-ray abnormality, and changing that X-ray abnormality isn't necessarily going to improve your quality of life. So when you're talking to your orthopedic surgeon or your physicians in general, this is always the question that should be in the back of your mind when you're talking, especially if you're talking about a very significant surgical intervention. We always talk about alternatives to surgery before we talk about surgery. So just like anyone else, patients with MPS will benefit from keeping their weight down. If they need an assistive device, they can become more mobile and maybe avoid surgery, braces, shoes, etc. And we always talk about pain relieving medications, non-steroidal anti-inflammatories such as ibuprofen, naproxen, i.e. Aleve, Tylenol are really helpful. Sometimes we talk about injectable medications such as corticosteroid injections. So these can delay the need for surgery. So sometimes we do all that and it doesn't work. So then we talk about an operation. There are some cases where you don't need, and we'll talk about like particularly for hip dysplasia where it doesn't necessarily follow that course. But when we operate, it's usually pain or deformity that limits everyday activities. Nighttime, rest pain, certainly. When we're talking about spine differences, or we're talking about carpal tunnel syndrome or tarsal tunnel syndrome, we're talking about neurologic changes that might be subtle. Or again, as I mentioned with hips, it might just be an unfavorable natural history. But it's not that when you're talking about natural history in MPS, we still don't have great understanding of what to expect in the long run for a lot of situations. And so we're kind of left guessing. Don't memorize this chart. This is just to point out that there are a lot of orthopedic issues that you can run into. And I'm going to talk about all of these except carpal tunnel syndrome because we have an esteemed guest today, Dr. Azaki, who's going to be talking about that. So she's much more capable of talking about hand issues really than I am. So I'm going to just kind of work my way from the spine down to the feet. And so the most critical issue probably that we talk about is cervical spine issues. And we talk about stenosis, which is just a medical term for narrowing. So we have narrowing of, so Dr. Brown was talking about aortic stenosis, that's narrowing of the aortic valve. Spinal stenosis is narrowing of the spinal canal. Instability, and I'll show you a little picture of that in a second, is when the vertebral bodies move on each other and that can pinch the spinal cord. This can happen because you have small bones that don't leave enough room for the spinal cord to start with, or there can be ligamentous laxity between the bones, which can cause a pinching of the spinal cord. So here's a nice little animation which shows that's your spinal cord getting pinched, and the spinal cord doesn't like being pinched very much. So. And this is just some X-ray, MRI, and CT findings, which show a situation. This is an MPS 6 kid. You can see on the right side, that's an MRI. Hopefully you can appreciate that little blush of edema in the spinal cord. There's a kid who fell, knocked his head, and ended up quadriplegic temporarily, but was able to be stabilized and did well in the end. When should we worry about spinal cord compression? Well, symptoms are what we call myelopathy. This is when you start getting weak in your legs or your hands, your arms, clumsiness, difficulty holding things, or unsteady gait. And then late findings would be bowel or bladder problems. So initially it's bladder retention. So you may, most of us urinate 3 to 5 times per day, but if you're only urinating once a day, that's a problem. And then eventually if your bladder gets too full and the muscle fails, then it becomes incontinence. And that's a very late finding. We don't want to get that far. For instability, sometimes the muscles are working hard and that can cause neck aches or headaches. And that's going to be more, probably, we're talking about Morchio patients than other MPS patients. So if we do get to surgery, which oftentimes we do, then we're going to operate if there are, again, neurologic changes I talked about earlier. There's obvious instability, so that's a sign that the natural history is going to be poor. Or as I showed on that MRI, the cord has already been injured and we want to protect it and keep that from happening again. So this is just a little animation that we put together on what that surgery looks like. So there you're taking off the compressing bone, you're allowing some spine, room for the spinal cord. You're going to put in some implants to stabilize that and then put bone graft around it, and that's what we call a fusion. So this is an instrumentation and fusion, and usually in kids with MPS, their bones are too small just to go to C1, C2, so we usually are instrumenting up to the skull. Moving down the spine, we're talking about thoracolumbar kyphosis. This is the most common presenting deformity that we see. 90% of hurler kids present with a thoracolumbar kyphosis, and I will say a lot of my Morchio patients have presented to the orthopedic office before anyone knows what's going on because of this kyphosis, which you can kind of see on this little child's back as she bends over. We can watch these for a long time, but we know that curves that are a little bit bigger, like 45 degrees or more, will tend to progress. And sometimes they can cause neurologic compromise. Mostly they're just going to be a big deformity that can cause pain and more disability as you get older. So the surgery here is going to be taking this kyphotic spine. So that's a forward bend in the spine. And we're going to do what we call osteotomies. And I'll show this to you again in animation. We put instrumentation, we fuse it. We want to get the spine well aligned so that it's balanced. Some people, most people will go from all posterior approach, resect some of the bone, put in the implants and get that spine straight. And then I always recommend for MPS patients, because they're small and their bones are small, the fixation may be a little more tenuous, is to put them in a brace afterwards. So this is what the x-ray looks like. That's the fusion in the front. That's the instrumentation in the back. And again, here's another animation to kind of show you what we're doing as surgeons. We're taking all that bone away in the back of the bone, and then we line it up. We put these implants in. Again, like the cervical spine, we'll put bone graft around it. That bone graft consolidates into what we call a fusion, and that's what holds the spine straight. And so when we talk about instrumentation fusion, think about it as concrete and rebar. If you have one or the other, it's okay, but it's better to have both. And these days we have implants for small children, and I was doing a surgery on a child with osteogenesis imperfecta earlier this week. The child's spine was about that long, and we put cervical spine implants in. And I think so. We have ways to deal with these really small children if we need to. And this is just an x-ray example. On the left, you can kind of make out that kyphosis. You can see it better on the MRI in the middle, and this is what it looks like on x-ray at the end. Scoliosis is much less common in MPS. We do see it. It tends to be a spiraling of the spine around that kyphosis. The difference between kyphosis and scoliosis is that because that forward bend in the spine, if it's high enough, it tends to put pressure on the neural elements. Scoliosis tends to put pressure on the chest. So by the spinning of the chest wall, you get restrictive lung disease. And so scoliosis is more of a pulmonary problem, whereas kyphosis is more of a neurologic problem. So you're treating them for different reasons, but in MPS, you tend to get both because it's this spinning around the spine. And so we can try casting and bracing at a young age. Growing rods are an option. I'll be honest, I've never put growing rods in an MPS kid. I just haven't run into that situation. After about age 8 or 9, we will do what's called a definitive fusion, which is very similar to the surgery I just showed you for the kyphosis, where we put rods and bone graft in. And I think the thing is to understand that for any of these surgeries, the complication rate is for kids with MPS is going to be higher than your standard population. And that can be for cardiac, respiratory, GI, or just because they're small and their implants are probably big relative to their body. So we can run into you have to be expecting some problems with a big surgery. This is a Morchio patient of mine who had scoliosis. You can kind of make out where it's spinning around that kyphosis. And then we put these screws and rods in, and I won't bore you with another video there. Moving down to the hips. The hip situation is really complicated because we have deformity, but we also have biology. And so that inflammatory disease, as I kind of alluded to at the beginning, results in hip arthritis. And the hips are really abnormal. And so the question becomes, if we fix the deformity, does that give you a good long-term solution relative to, sorry, I was just looking at the clock, but does that give you a good long-term solution? Because if the hips are going to degenerate anyway, and you do all this deformity correction, is it really worthwhile? And I will say, I think for Morchio, it probably is worthwhile. For Hurler, I think the jury's out. And for the other forms of MPS, I don't typically operate on the hips. I haven't found that to be necessary to do deformity correction on them. And I'll show you a little bit of how this works out. So this is just so just for your reference, I put normal hips on the left and MPS 1 hips on the right. And this is a closer look at that. And so what we see is what we call a break in Shenton's line. So the dotted line is where that femoral neck should be, and the solid line is where it is. So you can see it's shifted up. They have a really high, what we call neck shaft angle. So we call this coccyvalga. And then we have a really shallow acetabulum here. So an increased acetabular slope. And the combination of all of these bony findings results in subluxation of the hips. The hips don't like to be shucking in and out of joint. That's a setup for bad hip disease. So when we see this subluxation, particularly for me in Hurler syndrome, but we almost always see it in Morquio syndrome, that to me is a reason to operate. And what we do is what we call hip osteotomies, and that's where we cut the pelvic bone above the hip joint, and we cut the femur below, and we turn the bones in. If you happen to go to DuPont, they like what's called a shelf acetabuloplasty. It's a similar version, and the outcomes are the same, and if not, well, they're the same. So this is the way I would go about this. I do this pelvic osteotomy, is what it looks like on X-ray, and then you can see the implants holding the femurs together. And again, here's another video that really kind of shows you what we do. We cut the femur, we take this bone chunk out, we align it into the hip, and then we go up to the pelvis, we cut the pelvis, we take that bone graft, we stuff it in there to hold that down. And then what you'll see in the end here is we'll show both hips, and it's subtle, but if you look at the left hip compared to the right hip, you can see the right hip is still kind of sitting out of the socket, and the left hip is sitting very nicely in the socket, okay? So this is what we're trying to achieve with these surgeries. So as I said, the jury is a little out on Hurler syndrome. I think in Morquio, the sort of the 10, 15-year outcomes are pretty good. And I can tell you the Morquio patients have a lot of pain with hip instability. And as soon as you do the surgery, they feel better. So I have no qualms about operating on kids with Morquio syndrome. For Hurler syndrome, they need to be showing that subluxation that I showed earlier. If they're not showing that subluxation, I'm going to leave them alone, because what happens is you look from surgical group to non-surgical group, that it's equal numbers of kids who developed arthritis after 10 to 15 years. And the Irish experience is the same, where you see these you see advanced, it's probably a little hard to read, but it's advanced hip disease in a lot of these patients. And if we look at their functional outcome scores, these should be 75, and a lot of these are below 75. So by doing hip surgery in Hurler syndrome, we don't necessarily make them better because of the biological issue. And so that's what I'm going to talk about next, is the biological issue. So that leads us to joint replacement surgery. So for teenagers or adults who have biological hip degeneration, we're going to talk about a hip replacement. And so because MPS patients tend to be they're not out running marathons typically, they're what we call a little more low demand. And because they have these medical comorbidities, which contributes to that, we will do a hip replacement. Now, understand that a hip replacement in a patient with MPS is going to be very different than a hip replacement in, say, your grandmother, or if you're my age, it'd be your parent. But where they're otherwise healthy, normal anatomy, and the hip replacement surgeons have these mills that they run through, and they can do 5 of these in a day. That's not going to be your MPS patient. That should be the sole focus of your surgeon for the day. So, and this is what we do with them. As you can see here, the red is, well, we'll come back to the femoral head, which is degenerated. And what we do is we remount the cup, the socket. We put in these metal backings. These can either be with cement or this roughened surface for bony ingrowth. You'll then end up putting in a plastic liner. You cut off the femoral head. You put a prosthetic into the femur, and I'm sorry, wasn't able to speed this one up. And so here you take that off, and then this is what a hip replacement looks like. It's a prosthetic hip. Similarly, for a knee replacement, you'd cut off the ends of the bone on the knee and put metal and plastic implants as well. Now these days, hip replacement surgeries will last 20 or 30 years, and if you are a lower demand patient, then they can last even longer. So this is a really effective surgery for that biological problem. I will say that sometimes if we do those osteotomies I talked about, you can make this hip replacement harder. So that's why if patients really don't show signs of having a problem that I think needs to be fixed, I would rather wait until they're teenagers or young adults, not do surgery to them as children, and then let them have a hip replacement, which is less complicated when they become teenagers or young adults. Moving down to the knees, knock knees are just sort of part and parcel of MPS. This is a hurler boy, but you see this in all forms of MPS. Knock knees aren't the end of the world, but if you imagine trying to walk with your knees together and they're crossing over, this can definitely affect mobility. The good news is this treatment for this is relatively low risk and relatively easy. We do what's called guided growth. And what we do is we put little plates and screws in. Some people call them 8 plates, but that's actually a trade name. It's like saying Kleenex as opposed to tissue paper. So, and most of us don't use 8 plates. We use other brands. But you can see by tethering the inside of the knees, we were able to get these to grow out away from this midline. And in this case, I purposely overcorrected. You can see this patient is actually a little bow-legged because with MPS patients, especially the younger you are and the more growth you have left, the risk of recurrence back into knock knees is very high. So we tend to overcorrect them a little bit, let them fall back to neutral, and hopefully they don't need a second surgery. But if you have a child who's like 4 or 5 with severe knock knees, we get them corrected by age 6 or 7. We take the plates out. Just be prepared that you might have to go back and redo that. And again, here's that surgery. You have these plates that are about the size of a paperclip. We put it on one side, it allows the other side to grow. And by doing that, then the legs will grow straight. So this is guided growth. You don't go into surgery and come out the same day with your knees straight. Okay. It takes a year or 2 or more, depending on how fast the kids are growing. And so that's what guided growth looks like. Moving down to the ankle, tarsal tunnel syndrome has been talked about. And I put it here because everyone always asks me about it. I've never seen it. And I know, I think, Dr. Munzer, I think you guys probably check for it routinely or no? No, okay. But you might see it more in is you seeing it more in Hunter, you think? Yeah, okay. So plantar, theoretically, it's very similar to carpal tunnel syndrome. You can get plantar foot pain, so on the bottom of your foot, numbness, tingling. I will say that the science on this is pretty soft. And really what happens, if you look at the one paper on this, they had 4 patients with suspected tarsal tunnel syndrome. 3 of them actually underwent surgery for it, 2 with the good results. So 50% response rate. And one of the patients actually had spine problems, didn't have foot problems. So of 4 patients identified, really only 2, I think, benefited from any kind of treatment. So I think I think the jury's still out on this. Something to think about, though, if you see changes in gait. And Dr. Bronlin already kind of talked about this, but I think it's worth reiterating. If you're going to be having surgery of any kind, whether that's cardiac surgery, orthopedic surgery, hernia repair, airway issues, tonsils, adenoids, always need to have a very thorough, make sure your surgeon, and so orthopedic surgeons, we're kind of known for being dumb. So they don't know, they kind of just rush into things and without really thinking about the whole patient. And so it's your job as family members, or if you're an adult, making sure that you get a good cardiac workup, you get a good pulmonary workup. Make sure you see the ENT because, as Dr. Bronlin mentioned, airways are a very significant issue, especially in Hunter and Mertolome. And I would say probably, attenuated MPS 1 is worse than actually Hurler in a lot of cases who've had transplants. So just kind of keep that in mind. You need to have skilled airway personnel. You need to have an anesthesiologist who is used to difficult airways. Do not go to some Jack in the Box type shopping mall outpatient surgery center. That is where people die. Seriously, I've seen it, and so you need to go to a hospital with an anesthesiologist who knows what they're doing, and you need to have a backup team of ENTs, and you need to have an ICU available. You might not need the ICU, but you need to have it available just in case. And as talked about, by Dr. Bronlin, so Dr. Georgiadis and I and the DuPont team all worked together on the paper that she presented about neuromonitoring. And so this is a patient of mine, this MRI, it's a little hard to see, but what you see there is this is a little bit of a kyphosis. I did what I thought was a beautiful hip surgery on this Hurler patient. This was 2009, and she woke up paralyzed. There are dozens, it's literally dozens of patients now who have had some kind of orthopedic surgery where they weren't doing spinal cord monitoring and the patients wake up paralyzed. So if you are having surgery, if it's more than 45 minutes or an hour, because that's about how long it takes to really have a problem. And if you're in and out within an hour, you're not going to do anything different anyway. So, but if it's going to be more than 45 minutes an hour, then you or your child need to have some kind of monitoring. And so it gets very confusing for the anesthesia team and the OR team because they think that we're worried about their necks. And what we're not worried about their necks. We're worried about lower. It's their upper thoracic spine. And this is an instability issue. This is not a mechanical issue. This is a blood flow issue. So for some reason, and it's probably something about MPS small vessels and how they perfuse the spine there. And they get what's called an ischemic event. So basically a heart attack of the spine. And so the blood flow is gone. And so I've had many patients where I've started surgery and I've just bailed out because I'm like, I'd rather you have bad hips than and walk than be paralyzed. So I cannot emphasize, if I haven't emphasized this enough, we call this spine at risk. And so it's something to be very thoughtful and know about. I think, so I'm part of what's called a group that's called the Skeletal Dysplasia Management Consortium. You can get a lot of this information off this website. And there's some free resources to families here. It's skeletaldysplasia.org. We don't make any money off this. It's just, this is free. This is a service we offer. And I recommend that you go look there. And so key learning points, spinal cord compression is common in all forms of MPS and ML, requires regular evaluation and surveillance. There's a little bit of, play in how often you do MRIs and that sort of thing. And I think you just need to work that out with your doctor. Hip dysplasia and MPS 1 and 4A is common and often needs to be treated with surgery. They still get inflammatory, we call it epiphyseal dysplasia, which may require a joint replacement at some point in your life. Knock knees develop early in childhood, respond well to a very low risk surgery. So I'm pretty aggressive about treating knock knees. And then peripheral nerve compression. Dr. Zaki is going to talk about carpal tunnel syndrome, but tarsal tunnel syndrome also occurs. And so just that definitely needs to be monitored for. And then airway evaluation, neurologic monitoring are critical to any surgery. So for that, I thank your attention. And if you like these videos, they're out. You can go watch them out front. We have a booth out front, but they're also available on YouTube. And it's Children's Hospital Colorado YouTube. And just put in. I just Googled. I did it myself last night. So Children's Hospital Colorado YouTube MPS, and those videos I have two different videos that are animator made, and they're really fantastic. And if you want to take a look at them, go for it. So thank you for your time. I don't know. Are we taking questions, Terry, or do we have more dance music? Amber, okay. Yeah, Joe. Sanfilippo hips. So fair enough. So we did publish our experience with orthopedic abnormalities in Sanfilippo. Now it must have been 2008, 2009. Time flies. There wasn't, to be fair, there hasn't been a lot of orthopedic interventions on Sanfilippo. That's not to say that they don't have orthopedic problems. It just depends on how quickly they're advancing. And we know there's a lot of variability on how quickly these kids decline neurologically. And obviously, we all hope that soon we'll have some way to stop that, which, like Hurler syndrome, before bone marrow transplant, it was like, yeah, you got bad hips, have a nice life. What you got? A little morbid, but true, right? So But we do know they can get the epiphyseal dysplasia. I've not seen kids with hip dislocations with Morchio, with Sanfilippo. Again, it just depends on where they are in their life journey. And so again, in the end, that is really a one-on-one individual discussion with the family about, are we going to change your function and your quality of life by doing surgery? And so again, and I think that's really, really individually dependent. And so it's hard to make but I have seen kids who've had surgery. I don't know how great their outcomes were. We didn't really look at that. I know some could develop scoliosis. Again, you have to decide, is it worth intervening on? So
We got another question back here.
yeah. Oh,
Hi. You were talking about protection of the spine during anesthesia, and we didn't quite catch what you were saying in regards to what should be looked over below the neck area.
oh yeah, sorry. Yeah. So I kind of skipped through that. I'm sorry. So when they're having surgery, so when we do spine surgery, it is standard of care that we do spinal cord monitoring, because it's obviously much more common if we're messing around with the spine that we can stretch the spinal cord or even injure it with like a screw or something. So what and the picture kind of showed it. We do electrophysiological monitoring of the spinal cord during surgery. And depending on level of concern, sometimes we'll put all the monitoring in before we even do the prep and draping and all that kind of stuff, depending on level of concern. Oftentimes, we'll get everything ready to go, and then I'll put in the needles sterilely, and they're part of the surgical field. But either way, what it is you have someone in the room who's monitoring the activity of the spinal cord through needles that are in the lower extremities, and we use the hands as controls to make sure that the spinal cord is actually conducting nerve signals during surgery. Does that make sense?
That does make sense. And is
Okay.
this for any anesthesia procedure?
Anything within
Specifically?
45 minutes to an hour.
Got it.
And if you get pushback on that, just show them the paper, because no one wants to have a child paralyzed after surgery.
Right. I do have one more question, and that's on growth hormones.
Mm-hmm.
We have two with MPS 2, 6 and 8, and two very different body structures. Our 6-year-old is kind of long and lean, and our 8-year-old is short and stocky. We suspect that our 6-year-old will bypass our 8-year-old at some point. And I'm just curious if there's any, or what the benefits might be, or when or why you would consider growth hormone.
I wish Linda was here. And I can let some of the other experts in the room. I will say it's a mixed result with growth hormone therapy, because most of these kids are not growth hormone deficient. So by giving them what we call super physiologic doses, there are some kids who respond. I would say it probably doesn't work very well. The interesting thing, though, is for our other skeletal dysplasias, there are a lot of new growth therapies that are now being looked at in a trial, in an investigative way, off-label, that may actually improve growth in MPS. We don't know that, but people are looking at it, and so, it's a totally different mechanism than growth hormone, and it's really at the level of the growth plate, as I showed, and so I would keep my eye on that, but that's. If you have a endocrinologist or a geneticist who's willing to kind of look at that off label, it might, if you're really concerned about stature, that may be something that will come down the line. Yeah. Yeah. Here, Paul, she was first. Yeah.
If you had a neurosurgeon get an MRI, have your child have an MRI, and they looked for cervical stenosis in preparation for surgery, and they say, oh, it looks pretty good, doesn't look like you have an issue. Am I hearing you also say that you shouldn't stop there? You should still advocate because of the potential of decreased blood flow, which can cause an ischemic event, even though the cervical canal looks not stenotic at that time.
That is
Am I
100% the message.
Okay, 'cause
So
there's
if you
another
get
element.
that. So again, if you have a normal spinal canal without spinal cord compression, you still can have a spinal cord infarct lower down in the spine. So yes, it doesn't matter what that says. The MRI is not relevant.
We
Yeah.
are ahead of schedule, so we do have
Okay.
some more time if you're all right with that,
Paul,
Dr.
I think
White.
you were next. Oh. Yeah.
So my daughter, MPS 3B, we're working through trying to identify what's going on. She's complaining of back pain constantly. And so she just had a ultrasound, and they found a 5 centimeter mass on her liver. So she's going in for an MRI. So just going back to the monitoring of the, should we
Yeah.
be looking for additional monitoring?
So you can't do it during MRI. The needles are metal and the magnet will just pull them right out and probably stab someone.
Yeah, that's what
I mean, I think they need to be aware of it. And if I assume she'll be sedated for the MRI.
yeah.
So, generally an MRI can be accomplished in under an hour. Sometimes what we'll do is, we'll do an MRI and then we'll go do a dental examination and then we'll do an eye examination. And that's when I start getting nervous, but so if they're going to do that, usually you do the MRI first or last, and once you've established that everything's okay, or you get to it pretty quickly and then do the neuromonitoring for the rest, if that's the way it's going to go. But you can't do it during MRI, unfortunately.
Got it. Just real quick, one more question. Do you, in your opinion, obviously I have no idea about her, could this mass on her liver be causing the back pain?
I would say generally no. Liver masses are typically not painful and certainly not something we associate with back pain.
Okay.
You never say never. I learned a long time ago, you never say never, but I'd be very surprised.
Okay.
And, and I would say, how old is she?
She's 16 and she's annotated.
Yeah. So, that's the age, I call it old man syndrome. Our teenagers with MPS, they really kind of start slowing down. They get a lot of aches and pains. It gets back to that inflammatory kind of degenerative disease, and it does affect them. And so they do start slowing down and start feeling it. And unfortunately, I don't think there's a good intervention other than sort of pain medications. And
Thank you.
Klein, you might, I don't know if you've shifted to doing chest CT reconstruction of the airway. It was suggested at some of these workshops looking at pulmonary disease recently in the UK and Europe. It's been extremely helpful for our last 3 Morchio surgeries. And one, you see an incredibly narrow airway at the manubrium it's not as easily seen inside as it is outside when you do a CT reconstruction. I never did it.
yeah, you're talking about
last
tracheal
year.
stenosis.
It goes down to 2 to 3 millimeters, the
Mhm.
trachea, when you look at them, usually at the
Yeah.
level of the manubrium compressing, and there may be other vascular structures compressing at that point, and that changes their team meetings. Everybody knows the problem. The size of the tube that they pick to go with is very different, and it just raises everybody's level of
Yeah.
awareness.
So
And
so obviously not an orthopedic issue, but so I will say and Jen and I haven't really I don't think we've really talked about this too much, but even in Seattle, we didn't do routine CT 3D reconstructions of the airway. I will say the one patient we had, it was very obvious. She had obstructive airway disease. She would be in the room and she'd talk like this, and she was having sleep apnea from it, and she wasn't sleeping, and she was tired. Well, she wasn't sleeping at night, so then she slept all day. I mean, it becomes, and so the question with the tracheal reconstruction, which is totally out of my league, is it's a pretty significant intervention. And so they have to be relatively symptomatic, I think, to intervene. But I will say, again, the DuPont group has had a lot of experience and pioneered this idea. I think, if you have a skilled pediatric ENT team and chest surgery team, it should be reproducible in other institutions.
Yeah,
So-
none of these 3 Morchio patients had any of that, but
Did you do PFTs on them? Did they have obstructive
they
airway
weren't
disease?
having sleep apnea. We
Yeah.
weren't doing PFTs.
Yeah, the one we had a
but-
really bad, obstructive airway
Mhm.
disease. So,
But so I would probably do it on all Morchio patients, and I don't know
yeah.
whether
Yeah.
we need to do it on other MPS.
Yeah, again, I'm not an airway doctor. I think we'll probably hear about that a little more later, but
There's the other question, the other suggestion, my sense, and we did have one of your type of cases at UCSF, and there's a period where a good anesthesiologist puts the airway in, relaxes, starts working on lines, and they
Mhm.
don't watch blood pressure at that
Yeah.
point. And things
Yeah.
drop to a mean of 50 or
Yeah.
60. They really, that's the critical, and you actually lose signal before you even start your procedures.
yeah, I think that's a really important point. So maybe I should make that clearer. So because this is a blood flow issue to the spine, when I'm in surgery for an MPS patient, so when we take a blood pressure, we have the systolic and the diastolic pressures, but what we look at is called the mean arterial pressure, or MAPS. So when I'm in surgery with an MPS patient, I want to keep so our normal MAPS are usually in the low 60s. If you look at most kids, they can drop down into the 50s because they are under anesthesia, and even the 40s. And that's probably what's going to result in that ischemic spine problem. We tried to look at that in the paper, and it was really hard to parse out. But I truly believe that that's the issue. And so I will tell them at a minimum, keep your MAPS at 70. And if they're really high risk, I always keep the MAPS at 80. So if you're talking to an anesthesia team, but what this also requires is what we call an A line, arterial line, to monitor those very closely. So they're probably gonna have to put an arterial line in, monitor your MAPS, and probably want to keep them above 70 at a minimum.
Just MAPS are, explain what MAPS are, mean arterial pressures.
Yeah, I think didn't I say that? I said it. Yeah.
Yes, they're looking at going.
I know. So just, again, you can go online, you can download their patient-friendly questionnaires for your team and just say, this is what I need to know about. Did you do all of this? And are you aware of this? And, that's our burden in life, is to tell our physicians who are being obstinate that our patients are different and they need this. So you got to be mean. I don't know what else to say.
So Klein,
Yeah. Yep.
one comment in terms of the Sanfilippo, I would be surprised that they have the same risk of cord involvement because they don't have the thick endura. And so they have a much more,
Yeah.
what's probably much better than we would see in MPS 1 or 2.
Yeah. And to be fair, we just don't have that much surgical experience in Sanfilippo because most of the time we don't operate on them. So, but yeah, I mean, yeah, sure. I would defer to you on that.
Thank you, everybody, for your
right.
questions. Dr. White will be around. Oh, Terry's got a question.
I don't know if the time is right there, but are we good?
Very good. Going to come from a different place. How often our patient communities living so much longer? They've had successful surgeries, orthopedic surgeries, long surgeries, hip surgeries. Are you starting to see some of our patient community coming down? Because it's time to have a review or a change. I'm asking for that for myself. My daughter, she's 25 years into a military course to her full back reconstruction for severe kyphosis, which she's doing well, but it's 25 years.
Yeah.
So just talk about what you might be seeing on patients that are.
Sure. Yeah. That's a great question. So I think for spine surgery, if they're fused and they get out of the first few, 2 to 3 years, they're good to go. Now you can develop adjacent level problems, so above and below the fusion. But if they're well aligned and they have a fusion, then they're probably good to go. Now hips are totally different. Now, if like I said, if I do a surgery on a hurler kid at age 7 or 8, there's a good chance they're going to need a hip replacement when they're young adults. And so that means, so saying that they will probably need another surgery. Now, joint replacement surgery, as I said, generally should last a good 20 to 30 years, but it's a mechanical device. It will wear out eventually, especially if you're more active. So, it's really variable on how active our MPS patients are. So that kind of dictates that. And the other part of it is that because their anatomy is different, the implants, that 20 to 30 year rule might be a little less because the implants don't necessarily fit exactly the same as they would in, a typically average, statured adult would.